Thank you, Marty, and good evening, colleagues. So I'm going to talk about severe acute malnutrition today, and it's a very broad topic. So I'm just going to focus on some key aspects that I think are important in terms of management, and especially the nutritional management. So to begin, I just want to get my disclaimers out of the way. I was a bit hesitant about this talk being recorded, but it is. But I would urge you to refer to the standard material that's found in the WHO guidelines and in UpToDate, and adapt that to your local circumstances when talking about the management of malnutrition. And I'm not presenting any of my own work here. This is a summary of work done by other experts in the field. I also think that malnutrition needs to be understood in a broader socio-political context. And so I will talk a little about that as well. So the talk will focus on 5 key areas. I'm going to just give an overview of the type of clinical problems that pediatricians would encounter both in state and private practice. I'm then going to focus on changes in the management protocol for children with severe acute malnutrition, and I'm going to focus on the nutritional management. We'll then talk about ready-to-use therapeutic food, and then I'll just give you some oversight about whether outpatient management of SAM is feasible in South Africa. And finally, I'll talk a bit more broadly about politics and poverty in SAM causation. Now, I can't talk about everything, so I'm not going to cover the clinical features of malnutrition or talk about the various anthropometric interpretations in SAM and in MAM. I would urge you to read the WHO guidelines as well as the integrated management South African guidelines, which were published in 2015. And even though this is very interesting, there just isn't time to talk about the recent advances in the pathophysiology of severe acute malnutrition. And so the recent research that's been done with regard to the role of the microbiome in malnutrition, as well as metabolomic and proteomic analysis in SAM, the role of 1-carbon metabolism, I would just urge you to look those up if you're interested in those topics. So my personal observations regarding the management of SAM is that we do some things well and we do some things poorly. So the things that we tend to do well are we're good at identifying and treating HIV infection promptly, and I think that's a very important thing. And we're not bad when it comes to treating infection and or sepsis, as well as dealing with the complications of hypoglycemia and hypothermia. So we do that well. However, we have problems in assessing dehydration in children who are severely malnourished. And we have difficulty in using intravenous fluid judiciously in SAM. And this is not just a South African problem, it's an international problem. But where we do fail is we don't institute feeding early, and we certainly don't supplement caloric intakes appropriately, in my experience at least. And community-based management is almost non-existent in South Africa. So what I'm going to do now is I'm just going to give you a minute or two to do this poll, please. So if you could just enter the following address on your browser, accept the cookies and enter your initials. There are 2 quick questions to answer. And if you could please do that, I'll give you about 2 minutes to do that, and then I'll continue with the talk. All right, I hope that was enough time for the poll, so I'm going to continue. And I'm now just going to give a broad overview of the spectrum of malnutrition that most pediatricians will see in South Africa in either state or private practice setting. So when I talk about the term primary malnutrition, I'm referring to malnutrition that's due to food insecurity mainly. And those patients will usually present to state facilities. If the malnutrition is severe, they usually present with the clinical features of kwashiorkor marasmus or marasmic kwashiorkor. Secondary malnutrition is present in children that are seen in both the state and private sectors, usually due to chronic illness. Usually manifests with marasmus if it's severe, but in all types of malnutrition, there's a spectrum of clinical presentation, and we could find children who are wasted, stunted, underweight, or have specific micronutrient deficiencies. And I'm going to specifically talk about nutritional management, and so the role of ready-to-use therapeutic food in primary malnutrition. And a question that I get asked regularly is how to calculate caloric requirements in children with secondary malnutrition. So I'll just spend a few minutes discussing that. So let's start with severe acute malnutrition and talk about the key changes in management. Now, in 1996, Anne Ashworth and Alan Jackson published the 10 steps. The 10 steps essentially is a form of a mental representation that assisted health workers in looking at important complications and directed them to appropriate management in children with severe acute malnutrition. And they're quite good, but the problem is we're kind of stuck on the 10 steps and we haven't taken into account the newer developments in malnutrition. So about 3 years after they had published their work, the guidelines were incorporated into WHO's 1999 guidelines, as well as the 2003 guidelines for inpatient management. In about 2007, WHO talked about the use of ready-to-use therapeutic food for community-based management of children with severe acute malnutrition. And the guidelines were then updated again in 2013 to reflect new evidence that had been accrued in the field of childhood malnutrition. So the key features or the key changes from when the 10 steps were originally published was that outpatient management was encouraged if it could be done so safely in children that didn't have any medical complications. And the second important concept was that there are different phases of treatment in malnutrition, stabilization, rehabilitation, and follow-up. And these phases are actually overlapping and they're not sequential. They don't follow one after the other. And that was a problem with the initial 10 steps to some extent, is that people tended to do things incrementally rather than simultaneously. And it's also important to recognize that malnutrition is not a homogeneous condition, and no two children are the same. It will manifest differently in different children. But I'm now going to give you a hypothetical scenario of a child who's admitted to hospital where we planned discharge after about a week of treatment and follow up afterwards. And for the sake of this talk, I'm only going to focus on children between the ages of 6 months and 5 years. We can discuss the management of malnutrition in younger children if you have any questions. But for this talk, I'm going to concentrate on this particular age group. So the first thing that you do if you see a child is initial stabilization. And initial stabilization deals with the acute recognition and treatment of life-threatening conditions. But what's important is that feeding should actually begin in this period of initial stabilization. Next, we talk about rehabilitation, and rehabilitation is both an inpatient as well as an outpatient duty. The key feature of rehabilitation is to empower the mother to care for the child at home, as well as to address any social problems that may happen at home, and to begin the stimulation of the child. In this period, typically, feeding is advanced. And finally, we have the follow-up phase, where the holistic management of the child, physical, mental, and emotional well-being is focused on. And what's important to know is that for both rehabilitation and for follow-up, these phases actually start when the child is admitted, and there shouldn't be a delay. There shouldn't be a lag period. And that's really important. So to put things together, if you're managing a child with severe acute malnutrition, we start the phases as soon as we can. They overlap. They should be started as early as possible. And we manage the child in a holistic fashion. So some of the difficulty arises, I think, on what to do during the first few hours of admission. And again, I'm going to use this hypothetical scenario of this child. And what we do is that in the first 30 minutes, preferably in a shorter time, like 15 minutes, if you see a child with complicated SAM, there should be a rapid clinical assessment. And hypoglycemia and hypothermia should be dealt with promptly, and antibiotics instituted for the empiric management of infection or sepsis. The child should also be evaluated for potential dehydration, and it's critically important that the history is much more reliable in terms of the child's hydration status rather than the clinical features for reasons that I will allude to later. But this needs to be done quickly. So as soon as the child enters a health facility, within half an hour or 15 minutes preferably, the child should be stabilized and antibiotics instituted for treatment of sepsis. So in this period, if you're not sure, some of the things that are difficult to do are to assess dehydration and to differentiate hypovolemic from septic shock. These conditions may all coexist. So I'll refer you to a text later, but this is what usually causes problems. And what we all don't know how to do is how to prescribe intravenous fluid safely, but I'll come back to that in a second. What I do want to focus on is the assessment of feeding. So after the child has been stabilized, we should assess feeding, and I've got it in the first hour here in this particular schema, but we should try and do it as quickly as we can. And we're going to be doing the appetite test. And essentially, we're going to make a decision about whether the child needs to be started on F75 or ready-to-use therapeutic food. And feeding should not be delayed. Even if you have a critically ill child, we should try and feed via an NG tube if possible, but certainly not later than the first 2 hours of admission. So that's really important. Now, many years ago, Michael Golden and Yvonne Grality wrote a very nice protocol in the management of malnutrition. It's quite long. It's easy to read, but if you want to understand the clinical features of dehydration and so on, this is the text that I would recommend that you read. So let's just briefly go through the management or the nutritional management. And what's important is that we feed as soon as possible. So as the clinician, the first decision you need to make is that, am I going to use ready-to-use therapeutic food, or am I going to use F75? So at the beginning, those are the only two choices that you have to make. And we determine this by doing an appetite test. And I'll talk to that later. But ready-to-use therapeutic food, if it is safe to do so, can be initiated from the time of admission. Now, if a child can't take ready-to-use therapeutic food because they're critically ill and we start feeding with F75, we repeat the appetite test every 1 to 2 days. And if the child passes the appetite test, we transition back to directly to ready-to-use therapeutic food. And if they don't, depending on the duration of admission, we either would continue with F75 or transition to F100. And again, after 1 to 2 days, we're going to repeat the appetite test. If the child passes, we transition back to ready-to-use therapeutic food. And if they fail, we begin the cycle again. So this is the overall schema that you need to know, and the decision-making process that you take in terms of nutrition. Now, importantly, I think it's important to know how many kilocalories to give to the child safely. So we start with 80 to 100 kilocalories per kilogram per day. And our target kilocalories is certainly about 200 or over 200. Typically, it's about 220 to 225 kilocalories per kilo per day. And we increase by 10 to 15 kilocalories per day. And now, most doctors would think, or South African doctors would think, that these are high amounts, but these are safe amounts for the management of SAM. Now, if the child is not recovering or not responding, I think it's very important to go through this checklist systematically. The one is, a common reason for treatment failure is what we call environmental failure. So these are the conditions at the hospital itself, where we have staff shortages, feedings cannot be done promptly, on time, or with sufficient frequency, or if the child develops a nosocomial infection. Another reason for not responding is that the nutrition is inadequate, or that there's an underlying infection that's not either diagnosed or treated appropriately, or that the child actually has some other undiagnosed medical condition, and this is not just primary malnutrition. Now, refeeding syndrome and early or late onset cardiomyopathy are complications related to feeding, but they're actually quite rare or uncommon with the use of ready-to-use therapeutic food. And I can talk to that a bit later, but these are the things that we look for when children don't respond to management. So I'm now going to talk about secondary malnutrition, and I'm just going to talk about the severe variety and how to determine caloric requirements. And this again is just a summary of information in UpToDate. The management is very similar to the management of primary malnutrition, but usually most of these children are hospitalized, and we transition towards target energy and protein intakes over 7 to 10 days. We begin feeds every 2 to 4 hours, and we prefer to feed orally or via the nasogastric tube. And again, as I mentioned before, this is usually secondary to a severe medical illness or severe psychosocial stresses. Now, I'm just going to give you an example next and go through this slowly. Let's just say we have a 15-month-old male infant who weighs 9 kilograms with a length of 78, and we want to determine what the starting kilocalories should be. So the first thing we do is we try and obtain the ideal weight for length. So this is very important in this chart. This is actually a weight for length chart. This is a length for age chart up above. And we find that in this particular example, the ideal weight for this child's length is 10.4 kilograms. So that's the number to remember. And next, there's an equation which you can look up, which is quite easy. So we enter the estimated energy intake for that child, multiplied by the ideal weight and divide by the actual weight to determine the starting kilocalories. And I'll tell you where I get this number from in a second. So this child should begin with feeds of approximately 96 or 100 kilocalories per day. And that's the initial energy target. We will adjust it according to the response. And again, in keeping with primary malnutrition, the child may require in excess of 200 kilocalories for adequate catch-up growth. And ideally, we'd like weight gain in the region of about 45 to 60 grams per day. So that's just putting that all together. And the number that I talked to you about, the estimated energy requirements, just comes from this table. This is just showing requirements for children under the age of 2. But you can just look this up, multiplied by the ideal weight and divided by the actual weight to work out how many kilocalories the child should get. Now, at this point, I'm actually going to stop and I'm going to ask Ziad to share the poll results with us. So I'm going to stop sharing. Ziad, are you happy to share the poll results?
Thanks, Sanjay. I don't stop sharing yet. We were just trying to put the poll onto Zoom because there was a large number of responses and the poll froze halfway through.
Oh, okay.
So I'm just going to put...
I think we will need to ask people to redo it. Unfortunately, I can't set it up while the webinar is ongoing.
Okay, no, that's fine. Let's not ask people to redo it. Let me just share what we got, right?
Would you like me to stop sharing?
Yes, please.
All right.
So this was based on 112 responses, and before the poll couldn't handle more responses. So Sanjay, I'll let you talk and I'll just change the slide.
Okay, so I mean the results kind of confirmed what we expected, is that the vast majority of people haven't used ready-to-use therapeutic food at their hospital. Yeah. And could we look at the next result? Okay, well, I'm glad that most people know what ready-to-use therapeutic food is, because I think people who haven't used it really don't know what it's all about. But I'll talk to that later. So yeah, thank you so much. I'm going to start sharing again. All right, would you let me know if you guys can see my screen again?
We can see.
Ah, thanks, Martin. Okay, so let's talk about ready-to-use therapeutic food. Now, ready-to-use therapeutic food is essentially a food paste, and it is a fairly simple food preparation that you usually make with peanuts, some milk, some sugar, some vegetable oil, and a commercial powder or powder that you get from WHO that contains all kinds of vitamins and minerals. And ready-to-use therapeutic food can be prepared in your own kitchen, depending on the volume, or the hospital's kitchen. And you can scale it up to industrial strength production, where you can export it to other countries and so on and so forth. So it's not a difficult thing to do. The recipe is freely available, and really anybody could do this if they wanted to. It's widely used in the management of malnutrition all across the globe. There are 2 South African companies that actually make the product and export it to UNICEF. The original product was called Plumpy Nut, and it was developed by Andre Brend, who formed the company called Nutriset that was based in France, in Paris. So they were the original formulators of this particular product, but there are lots of companies that make the product now. So a sachet of ready-to-use therapeutic food for severe acute malnutrition, it comes in different formulations, but the one that we use usually contains 500 kilocalories in a sachet, and the sachet typically weighs about 92 grams. So I'm now going to talk about an appetite test and how you do this. So when you see a child for the first time in hospital, the most important thing is to do initial stabilization first. So you can't do the appetite test first, because it takes at least 30 minutes to do. And in the first few minutes, we want to stabilize the child, get the antibiotics in and so on. Only after that will we do the appetite test. And we can't rush it. It takes 30 minutes. And if you rush the test, you'll cause problems, because you end up hospitalizing children who could have been safely treated at home. And we do the test if a child doesn't have any medical complications of SAM. that require immediate hospitalization, right? So if the sachet is available, we use the sachet, but you should always use food that will be part of the treatment. So in some countries, like in Southeast Asia, they use locally prepared formulations of ready-to-use therapeutic food. So that particular food should be part of the treatment. Now, there are two key things that we assess. One is that we ensure that the child is ingesting the ready-to-use therapeutic food spontaneously. And secondly, we assess that this consumption occurs in adequate amount, and the child should not be forced to eat the food. The mother could encourage feeding because the preparation may be unfamiliar to the child, so the mother can encourage but not force. Water should be made available. So if the child is thirsty and wants to drink water, they should be offered water whilst completing the appetite test. And we should observe the mother and child interaction. And again, it's about encouraging feeding. Healthcare workers should not intimidate mothers or the child to consume the food, in order to send them home. So that's an important aspect. And ideally, it should be done in a quiet and a private area in your hospital or in your health facility. So that's the appetite test. And this is a video. You can take a photograph of this particular slide, but this is a video that describes the appetite test, and you can watch it in your own time. When we perform the appetite test, we want to make sure that the child consumes this in appropriate amounts. And so this table gives you a guide as to what proportion of the sachet should be consumed. And importantly, this is an approximate estimate. It's a visual inspection. We don't weigh the sachet accurately before and after the feeds. It's just an approximate amount of consumption that the child does. So if you have a 10-kilogram child, we expect them to consume at least half of the packet during the test feed. Now, there are kind of lots of reasons as to why people don't use ready-to-use therapeutic food. And there's an argument that it's not a natural food and that it's expensive, that there was a monopoly by Nutriset, and that it disempowers local feeding initiatives and so on. But I'll talk to this later. I don't think any of these are real concerns in my opinion. There were concerns about potential nut allergy, but it seems to be a very safe product to use. The formulation of ready-to-use therapeutic food is always being questioned, and there are quite a few studies deciding on how best to prepare that. Recently, there's been a study showing that omega-3 rich foods are better than omega-6 foods when we look at cognitive function about 6 months after treatment. However, omega-3 foods are not as stable as omega-6 foods. And so there are all of these issues that nutritionalists or nutritional scientists are grasping with. The protein is usually cow's milk protein, and people wonder whether there are other proteins that are better, but cow's milk protein works the best for now. And there are concerns about contamination during the manufacturing process. So if this is not done in a designated facility with health checks and so on, you can get contamination of the feeds during this process. But the advantages of ready-to-use therapeutic food certainly outweigh the disadvantages. People complained about the cost, so I did a quick back of envelope calculation. So these are two South African companies that actually supply UNICEF. And this is the price in dollars of a box containing 150 sachets. So as an example, if I have a child who has a discharge weight of 10 kilograms and we're feeding at 200 kilocalories per day from day one for a 6-week period, the South African IMM program usually feeds for a month after discharge. But let's just be a bit generous and talk about a 6-week feeding program with the increasing in weight. We need about 200 sachets, which would cost about 850 or 900 Rand. And you need to take that cost into account versus the cost of hospitalization. Now, the cost of hospitalization in South African hospitals is notoriously difficult to determine, but it's probably between 3,000 to 7,000 Rand a day, certainly at Barra. And so you can see that ready-to-use therapeutic food is certainly a cost-effective intervention. And there are lots of studies that have shown that this is a cost-effective intervention, even though the product is expensive. And so, I'll just go through this. You can see that the price has steadily declined. The price of ready-to-use therapeutic food. These are from international suppliers. There were always arguments that Nutriset had a monopoly, but even when new suppliers were introduced, the Nutriset price, which is the line in blue, was always lower than the average price of other manufacturers. And you can see that about 60% of the market still belongs to Nutriset and about 40% to other developers. And so if you have a tender system that works properly, this is what happens. You get the market share is broadened and the price actually reduces. This year, they're concerned that the price of ready-to-use therapeutic food is going to increase by about 16% because of the war in Ukraine and a shortage of, and the pandemic and a shortage of raw materials. But even with the price increase, I think ready-to-use therapeutic food is still the best option for feeding children. So next, I'd like to talk about outpatient management of SAM in South Africa. And to understand this, I think we need to have an overview of the South African health system. So briefly, about 16% of the population will utilize public or private health services, and the rest the state, although there's an equal amount of money spent in both sectors. And that's, South Africa is a very unequal country. So the healthcare structure in South Africa works like this. Most people in South Africa live within 5 kilometers of either a clinic or a community or CHC, a community health center. And that's where they would present to initially. Although, if the case is complicated, they would then be referred to a district hospital, a regional hospital, and then to a central hospital, which usually performs an array of functions: secondary, tertiary, and quaternary care. So some patients would actually present directly to regional hospitals or central hospitals, and clinics may refer directly to regional hospitals. But by and large, that gives you an idea of the South African public health system. At the community level, there are about 56,000 community healthcare workers that have now been incorporated into the PACEL system. That equates to one worker for roughly 250 households, or roughly 1,000 people. On average, about 4 people in a household. And they're particularly skilled in providing TB, HIV care, as well as care for the elderly and palliative care. But they're very poorly trained in mother and child health. And what this means effectively is that in South Africa, community-based treatment of SAM is actually not feasible. And so if you have a child with SAM, almost all of them are hospitalized. Now, the South African integrated management, it's called integrated because community-based care is not possible. Integration refers to integration with IMCI management, okay? So in integrated management, we still recommend ready-to-use therapeutic food for severe cases, but for children with moderate malnutrition, meal-based rehabilitation that a dietitian provides is usually recommended for therapy. And if you look at the current suppliers on the tender for the National Treasury to supply nutritional products for both children and adults, you can see that the manufacturers of ready-to-use therapeutic food are not on the tender list. So that brings me to, I think, my final point, and that's to talk about poverty and severe acute malnutrition, because I think it's really important to understand this concept. It can, you can despair as a doctor when you treat children with severe acute malnutrition, but I think having an understanding of the bigger picture always alleviates despair to a certain extent, and you kind of know what you're doing, what works and what doesn't work, and why something is not likely to work. So a few years ago, I read a book by the economists Acemoglu and Robinson, who proposed a model of economic development and explained why some nations are rich and why some nations are poor. And I will, using this particular model, explain the role of poverty in malnutrition. Now, almost everyone agrees that malnutrition is caused by reduced intake of nutritious food, whatever causal model that you use, whether you're talking about the microbiome or any other model. And almost everyone agrees that this is true. But what's important to realize is that most people are hungry for reasons that are not what you think. And so what's very important to know is that a lack of food almost never exists, even in times of extreme famines. And so food is always around. The Nobel economist Amartya Sen, who I think must be in his 90s now, but as a child, witnessed the devastating Bengali famine of 1943, which is probably the severest famine recorded in recorded history. And Amartya Sen, years later when he did his PhD, made this very important observation that during times of famine, there's almost always good food around, but it's that the food is very expensive. And because people are poor, they don't have access to food. So I think this link is very important to understand, is that people don't have food because they don't have money. Now, the question is, what causes poverty? And in Acemoglu's model, they've dispelled various hypotheses. The geography hypothesis postulates that people in sub-Saharan Africa are poor because they live in hot tropical climates where agriculture is difficult and it's rife with disease like malaria. The culture hypothesis, which people would not talk about openly but privately whispered at lots of dinner parties and conversations, that people are poor because of their race or their beliefs or their religion and so on, or they're ignorant of economic policies that are going to facilitate prosperity, and that's known as the ignorance hypothesis. But very eloquently, they've dispelled all of these particular notions. And what they've shown essentially is that people are poor because they live in a country that has extractive political and economic institutions. Now, the political institutions drive a country's future, essentially. It's the most important determinant. And they're called extractive because wealth is extracted from the majority of people by a political elite. Now, in contrast, countries that are prosperous have inclusive political institutions. This is not absolute. There's always degrees of inclusivity and exclusivity in all countries. But inclusive political institutions have certain characteristics where individuals have secure private property rights, they subject to an unbiased system of law, and so on and so forth. That fosters the creation of inclusive economic institutions, and it leads to prosperity. Okay. Now, these two institutions, or these two scenarios, are not mutually exclusive. You can actually transition from an inclusive society into an extractive one, and you can transition from an extractive into an inclusive one. The transition from an extractive society is really difficult, though. It usually will take about 50 to 100 years to happen, and it depends on other factors that we have no control over, called critical junctures. But it can be done. It's just extremely, extremely difficult. And so using this particular model, if you look at South Africa was, for the vast majority of people who were politically disenfranchised and lived in poverty, both extractive economically as well as politically. When Nelson Mandela was released, that was a critical juncture that quickly saw South Africa transition into an inclusive political institution, although we still remained poor. I mean, most people in South Africa are poor, so the economy was extractive for most people. But sadly, South Africa is worryingly doing a U-turn as Zimbabwe, because our political institutions are also becoming extractive now. So the situation is bleak. And I think that's important to understand, because as doctors, when we talk about interventions for SAM, when we talk about refinements to protocols, or when we look for magic bullets, for example, an example would be ARVs in the treatment of HIV, we're intervening when the disease has already happened, but we're not going to stop the cycle of poverty. And so you can still expect to see children with severe acute malnutrition. In the United Kingdom, for example, after the Industrial Revolution and the improvements, we could see that social changes, if you look at TB, for example, there was a marked decrease in TB prevalence and mortality even before TB chemotherapy became widely available. And that's because there's an improvement in the political situation of a country. So I think it's important for doctors to understand this concept, this framework into why malnutrition occurs, and our role in this particular cycle. So I'm going to end the talk there, and I do think that as a mission for SAMPA, it would be good if we could get ready-to-use therapeutic food on the tenders and available at all hospitals, and possibly to institute community-based rehabilitation for children with severe acute malnutrition. I'd like to thank Shoaib Kachali, who's done a lot of malnutrition in South Africa. I've had lots of discussions with him, and I've received lots of useful advice, and I'm happy to take any questions. So I'm going to stop my talk, and I'll stop sharing, and I'll take questions. Over.